Hi, my name is Gilda Ulad. This is Group 19. Our presentation gonna be based on methotrexate. On this slide is listed the names of our group members, the drug name, and the drug chemical structure. Our objective for today will be the presentation of drug class, generic and brand name, methotrexate, mechanism of anti-cancer action, minor major adverse effect of methotrexate, drug interaction, pharmacokinetic features, and we'll also be talking about the mechanism of drug resistance of methotrexate. Methotrexate is an anti-metabolite drug used to treat multiple medical conditions such as cancer, psoriasis, rheumatoid arthritis, just by interfering with the cell growth. It is administered by intravenous, intrathecal, or oral route. Its renal excretion is mediated by glomerular filtration and tubular secretion. Caution should be taken with other drugs such as aspirin, NSAID, penicillin, cephalosporin, since these agents inhibit the renal excretion. Methotrexate biological effect can be reversed by administration of the reduced folate leucovorin or by L-leucovorin, which is the active enantiomer. Now let's talk about the drug class and the different brand name used for methotrexate. It is a drug with multiple functions listed under different pharmacological category. Methotrexate can be classified as an anti-metabolite, an anti-neoplastic agent, anti-rheumatic. It could be used as a disease-modifying immunosuppressant agent. Methotrexate has multiple brand names such as Otrexup, Rasuvo, Rimatrix, Trexel, and Zapmap.
Mechanisms of anti-cancer action. Methotrexate is a folate antimetabolite that inhibits cellular replication, DNA synthesis, and repair. It's specific for the S phase of the cycle. Methotrexate irreversibly binds to and inhibits dihydrofolate reductase, inhibiting the formation of reduced folates and thymidylate synthase, causing an inhibition of purine and thymidylate acid synthesis.
Along with its needed effect, methotrexate may cause some unwanted minor adverse effects. Although not all of these side effects may occur, if they do occur, they may need medical attention. You should check with your doctor immediately if you experience any of these following side effects, such as malaise, nausea, stomach pain, drowsiness, headaches, hair loss, blurred vision, leukopenia. These side effects may go away during the treatment as your body adjusts to the medicine. Also, your healthcare professional may be able to tell you about ways to prevent or reduce some of these side effects. Besides the minor ones, methotrexate also has some major serious adverse effects that you should caution about. You should tell your doctor right away or get the medical help if you have any of serious adverse effect following, including mouth sore, diarrhea, sign of anemia such as unusual tightness, pale skin, sign of liver problems like dark urine, persistent nausea, vomiting, stomach, abdominal pain, yellowing, eyes, skin, easy bruising, bleeding, black stool, enlarged lymph node, or bone marrow toxicity like bone pain, unusual pain and discoloration of the skin, change in the amount of urine, dry cough, muscle weakness. Besides that, you might experience neck stiffness, severe headache, vision change, irregular heartbeat, mental mood change, seizure, or any sign of infection like fever, chill, sore throat, cough, or any series of allergic reaction. Rash, itching, severe dizziness, trouble breathing.
There are many drug interactions with methotrexate. Here are some of the combinations to avoid. Acetretin may enhance methotrexate hepatotoxicity. BCG intravesical methotrexate may diminish BCG therapeutic effect. Difurapone. The combination use of difurapone and methotrexate may increase the neutropenic effect of difurapone. If unable to avoid combination, monitor absolute neutrophil count closely. Dipurone. Methotrexate may increase dipurone risk for granulocytosis and pancytopenia. Foscarnet may increase methotrexate nephrotoxicity. Natalizumab may increase adverse effects of natalizumab. Pimecrolimus may increase methotrexate toxicity. The use of methotrexate and tacrolimus, the topical form, may increase methotrexate toxicity. There are other methotrexate drug interactions and the mechanisms of the drug interactions. Methotrexate with NSAIDs and penicillins. NSAIDs and penicillins inhibit the transport of methotrexate via the OAT, which are organic anion transporters, resulting in increased methotrexate levels. Methotrexate and proton pump inhibitors. Proton pump inhibitors compete with methotrexate for transport via the BCRP efflux transporters, resulting in reduced methotrexate renal and biliary elimination with accumulation of methotrexate and increased risk of toxicity. Methotrexate and probenecid. Probenecid acts as an active tubular secretion inhibitor and prevents methotrexate from being excreted, therefore resulting in toxicity. Methotrexate and gemfibrozil. Gemfibrozil may increase the serum concentration of OAT-PIB1, SLC-O1B1, which results in renal toxicity. Methotrexate and vaccines. Methotrexate may reduce vaccines' therapeutic effects.
My name is Oscar, and I'll continue with the pharmacokinetic of this drug, methotrexate. So I'll be looking at the absorption, distribution, metabolism, and excretion. So this drug is dose dependent, looking at the absorption as it decreases as dose is increased, possibly due to saturation effect. It distributes slowly into the third space fluids such as the pleural effusions and the aside. From here, it slowly exits from this compartment. Then it is retained in the kidney and the liver. This drug is also 50% protein bound. Methotrexate is partially metabolized by intestinal flora after oral administration. It is also converted to 7-hydroxymethotrexate, which is a polyglutamate, and it is as potent as methotrexate itself. Bioavailability is dose dependent and it decreases as the dose is increased. It has a half-life of 0.7 to 5.8 hours for children, and for adults it is also dose dependent, as for low dose is 3 to 10 hours and 8 to 15 hours for high doses. The excretion is dose and route dependent as well, and 80 to 90% of the drug is excreted as in an unchanged form.
Primary mechanisms of drug resistance. We've found 5 different resistant mechanisms that have been described in cells that survive methotrexate treatment. Number 1, decreased accumulation due to impaired transport. Number 2, lacking of polyglutamate formation, decreased retention. Number 3, increasing in dihydrofolate reductase enzyme activity. Number 4, mutated dihydrofolate reductase that binds to methotrexate less avidly than the normal enzyme. And number 5, increasing level of a lysosomal enzyme, gamma glutamyl hydrolase, that hydrolyzes methotrexate polyglutamates.